All right. I think we're going to kick off, and I'll start with perhaps a quick introduction of myself, because I think I'm none of you in this room, perhaps except for a couple of people, will know who I am. So my name is Niels Fietje. I'm a research officer at WHO, at the European regional headquarters there, where I work on a project around cultural context of health, and I'll say a little bit about that in a few moments. But before I do, I just wanted to welcome you all to the 104th Global Health Histories seminar. We're joined by two wonderful experts who I'll introduce in a moment. And on this occasion, we'll be talking about tobacco control, the histories of and current global challenges around tobacco control. I'll say a few things about the Global Health Histories format and the webinar series, and also about the Collaborating Center on Global Health Histories. And then I'll say a little bit about the project that I work on, Cultural Context of Health, and then I'll introduce our speakers and we'll get underway. I don't want to take up too much of your time. I'm probably the least interesting part of this webinar. So the Global Health History seminars have been going for over 10 years now. They were introduced by Sanjoy Bhattacharya into WHO at Geneva as a way of bringing together both expertise on that kind of highest level within the organization to do with a particular global health histories topic, but to bring into that conversation as well a perspective from academia, particularly from the historical or social science or humanities and social science perspective. So it's really a unique kind of venue within WHO to bring together for an extended period of time, an hour and a half, sometimes 2 hours, these global health history personae from WHO, who are very often have crucial roles to play within public health, and to get them to kind of interface with and talk to people who have slightly different perspectives, humanities and social science perspectives, and who can challenge their perceptions of how they think global health history works, or global health works. Over the time, of course, the Global Health Histories seminars have expanded and have also become a little bit more flexible in terms of the types of people who are invited. So on this occasion, we have somebody from the Sri Lankan Health Ministry with us, rather than a WHO person, although I guess I still fulfill that role to some extent. But the basic premise still remains the same. The basic premise is to have somebody with practical expertise kind of face off with somebody who has a more historical, social, contextual understanding of the problem from academia. And I guess it's worth saying that the Global Health Histories Center, which Sanjoy Bhattacharya runs, has been kind of crucial in providing that venue for WHO. So much so that we have just renewed the the WHO Collaborating Center status, which York and Sanjoy has been holding for 4 years, and we've just renewed that for another 4 years. And I have to just want to reiterate that the work that you do, both in relation to global health history seminars and also to the kind of contextual work that you provide for us, is really particularly important to the project that I run. And maybe I say a little bit about that now, just briefly. So I run a project within WHO which is called Cultural Context of Health. And the basic premise of that is that, there's nothing revolutionary about it, but the basic premise is that pretty much every health challenge that WHO encounters has some kind of cultural context component to it. Sometimes it presents a challenge, sometimes it presents an opportunity. But in most cases, WHO isn't particularly well geared up in dealing with that challenge or opportunity, and doesn't always have access to the right type of academic expertise. So what the Cultural Context of Health project tries to do is to become a kind of cross-cutting initiative that presents those linkages, that provides those opportunities for academics from the social sciences, from the humanities, to interface with people from various parts of WHO, and to provide insight and input into the health challenge that they might be grappling with. So the project has been running for 4 years now, and as I mentioned before, the Collaborating Center here at York is doing great work to help us make those connections and build that work into the daily life of WHO. Right, so that's the kind of deep context, as it were. Now for the more kind of specific context, we have two speakers today in the kind of traditional global health history format. How we're going to do this is Dr. Lakshmi Somatunga is going to start with her presentation, and that will be followed by Professor Kamran Siddiqi, who will give both a kind of commentary to the presentation that he's heard, but also provide some other contextual background to some of the projects that he's working on. So to start us off with, I'll say a little bit about our two speakers. Dr. Somatunga is currently the Deputy Director General of Medical Services of the Ministry of Health in Sri Lanka, and has been a senior medical administrator since 2001. Having obtained her master's degree in public health in 1994 and her doctorate in 1999, she worked in different institutions in the health sector, and in her previous role, she was the Director of Non-Communicable Diseases, NCDs. She launched an initiative to do with tobacco control program and injury prevention for the Ministry of Health in Sri Lanka. In her present role, she works in tertiary care and healthcare quality and safety and nursing and medical services under her purview. Professor Siddiqi is a professor in public health at the Department of Health Sciences in the University of York. He has a medical background and further training in chest disease and public health, and has carried out research in the UK, Latin America, and South Asia in the area of lung health. So we were talking briefly, even though he is quantitatively trained, he also has a deep interest in the kind of qualitative context of the work that he engages in. And I think he'll be saying quite a bit more about that in relation to the projects that he's working on. So without further ado, if I could open the floor to Dr. Somatunga to give her first presentation.
Very good afternoon to all of you. First of all, let me thank the management and the administration of University of York for inviting me, particularly Professor Sanju Bhattacharya and our own Dr. Suranga Dolamulla, for inviting to share what we do in Sri Lanka. It's nothing like sharing. Let me start by taking you to far back at year 2000, where our proper program was started. There was a program, but a very comprehensive, organized, methodical program was started after 2000. This was the situation in year 2000. National level statistics was 25.8 was daily tobacco users among males in Sri Lanka. And it was less than 1, exactly 0.8% among females. And around 80% of smoked tobacco used as cigarettes. Other was BD, cigars, and other things. Then, those days, there was a vigorous campaign promoting tobacco promotion. You can see the two ladies that was taken from one very popular film where they wanted to promote, because despite the fact that it was 0.8%, and some wanted to make it a routine because it was unusual, smoking among ladies. But still, there was an effort to promote. That is why there were many scenes appear in some of the films. And then the other picture, a young lady is holding a cigarette. You know, this is called product placement strategy. If you know the advertisement strategies, because this was a big hoarding in front of a department store, especially selling clothes. So that is nothing to do with cigarettes, but the ladies is holding a cigarette. So this was that era. Then national program was initiated. I'm very proud to say then I was appointed as the director, non-communicable diseases. So we thought, I personally believe that you must hit the risk factors. If you look forward to a sustainable, steady decline of NCDs, you must intervene the risk factors. So tobacco being one of the key risk factors for major non-communicable diseases, heart disease, stroke, hypertension, diabetes, and cancer when you take, so it is one of the biggest risk factors with the physical activity and also the diet. But so with the objectives to deter taking up tobacco use, especially the children, and to maintain the non-use as it is, because we had non-smoker, because only 25.8% were daily male smokers, and to make public aware of consequences of tobacco use. If you see, all of these are primary prevention strategies. So we started with that. Some are primordial, you can see. As a public health specialist, we are believing in primordial prevention because before the risk factor occurs, you intervene. So all these were targeted on primary prevention. I don't say that we did not have anything, but there was no focus program on the affected, on the smoker. Later we realized that we must go into that area also, promoting quitting and other things. What was our guiding principles? It was multi-sectoral coordination because within the health sector, even because health is overlapping, there were many directorates. I was director NCD, but there was director mental health, where substance abuse was very important, and the smoking was part of it. And there was a health promotion bureau, and there was a directorate for youth. So all these are doing tobacco control. But we had a very good multi-sector coordination then, and it was very important to go outside the health sector because tobacco control goes beyond the boundaries of health sector. If you looking forward for a comprehensive control, you must go beyond the health sector. So what was our coordinated action? Really major measures were sensitizing professionals. It was very important, with all due respect to other professions, but non-medical, non-health professionals, although they are expert in their respective fields, they did not think that much of health because health sector was looking after health of Sri Lanka, So we want them to take part in respective professionals. For an example, in other ministries, we wanted to have a focal point. In fact, we had a middle-level manager and high-level manager, both, 2 persons in each of other ministries, like Ministry of Social Services, Ministry of Agriculture, Ministry of Trade, so on. We established focal points in other ministries. Otherwise, they never talk about this very nationally important problem which killed 30,000 people per year. And then heighten the role of media. Media was instrumental, really. Media usually, they highlight what is not their deficiencies. See, we encourage them to use their pen and whatever the media. I focus on the print media because it's so popular, on good things we do. So when we heighten the role of media, we had many seminars, many media briefings, what we are going to do, and they give their fullest support. So media was an integral part of tobacco control in Sri Lanka. I really salute them, the support they gave us when we had to face the legal challenge. So that is one of the major measures we had. And then capacity building of youth. Youth being very important segment of any population. You know, we have Ministry of Youth Services, Youth and Development of the exact name. Every district we have young coordinators. So we launched capacity building program for them. Initially we had to, that is unfortunate, but anyway, not so bad. Always we had to allocate our budgetary provisions. First 2-3 years we gave. Even the education is like this, because health is the baby of the Ministry of Health. But anyway, gradually from the 3rd year, they allocate their own budgetary allocation for their programs. But initially, we did it. That is, anyway, for nation's health. So, capacity building of youth was a major part, and early behavioral change in school children. I personally believe that this was our strongest part, because, you know, early behavioral change is more sustainable. So the school leaver or the person going to university or vocational training, if he or she is a smoker, he will maintain its status rather than intervene other people. I mean, over 40, 50, it's very easy and they grab and they maintain it. So early behavioral change was sustained in Sri Lanka. One special measure we did was inclusion of tobacco control into the curriculum of school children. We had grade 7, grade 5 we had, because for children you don't say no, everything. So we included that into other good health habits together with other things. And grade 7, 9 and 10 we intervene. And we have before university entrance, high schools, we have a general knowledge question paper. So we used to include questions. Whatever you teach, if you do not follow it up by asking question at the test papers, it is not so effective. So that is why we included questions in the ordinary level, not only in health and physical activity, because it's not a compulsory subject, only up to grade 9, it's in Sri Lanka. Now we are making arrangements to make it a compulsory subject. These days we work on that. Unless otherwise you include in English maybe, in science, wherever it's possible, we included tobacco control messages to them. So it was a very good intervention, inclusion into school curriculum. And engage in civil society, because they can work at the grassroots level. So civil society was a part of that. We had a stakeholder meeting involving them, and we follow up every 3 months. So that was a strength. What are the advantages gained by doing this multi-sectoral and coordinated action? Make difficult things possible, because it's not only health sector's responsibility. Tobacco control is, connected with behavior. It's difficult, but not impossible. So we have proved that. And it's comprehensive when we work together, and more effective and shared responsibility. Because it was totally, those days, the responsibility of the Ministry of Health. Now it is not so. Because there are other movements like health in all policies. So these are very good movements where we can incorporate our very important subjects, and we yield good results. I want to talk about mass media awareness, because we had some principles. Protection of the right to health. So these are our guiding principles. And community participation and empowerment and involvement of the community. Maybe most of you know that Sri Lanka is famous for its primary healthcare infrastructure. Our primary healthcare worker goes from house to house, looking after especially the children under 5 years, and eligible couples up to 49 years old. So when they engage in their primary duties, we utilize them to do other health promotion, primordial prevention. So they are with the community. So through them. And a very distinct feature of Sri Lanka is when the health Ministry of Health releases a message, it goes to doorstep, through this primary healthcare infrastructure. It's everywhere you can reach. And also cultural and social acceptance by all communities. Otherwise, nothing works in Asia. It has to be culturally accepted. And technically sound and evidence-based actions and multidisciplinary approach. Technically sound means we should not reinvent the wheel. We took all best practices from other countries, what they have done. Sometimes we learn from them and we modify it to suit locality, local needs, and we implemented. We did not want to reinvent wheels. As I said earlier, straight away we did not say tobacco is bad and tobacco control. But we integrate that into healthy lifestyle. So that was one of our success. It's a reason for success, especially for children and other workers also. Towards a healthy life, this is one of the posters we released of many. But I thought I will show this with the diet, with the moderate, this physical activity every day 30 minutes, and the options, and we say avoid tobacco. And we ask, what are the major components of healthy lifestyle? So like that. So any school child, if you ask the healthy lifestyle, they know. Avoidance of tobacco, take a healthy diet, and engage in physical activity. And apart from that, we had another campaign for coping up with stress. I'm failing in my duty as a public health person if I don't mention that. That's why I said. But for non-communicable diseases, we launched this program to get tobacco control as an integral part of healthy lifestyle. So that is one of the measures we have done. Then, this first ever public health treaty in the world was launched. It's a major thing done by WHO, which was really instrumental in tobacco control in Sri Lanka. I admit that. Because Sri Lanka participated in all the negotiations before the Framework Convention on Tobacco Control was born. We had to negotiate. Since 2000 up to 2003, every year there were 2 rounds of discussions with all the member parties. It was a little difficult. I was very fortunate to represent my country. I participated in all the negotiations representing Sri Lanka. So Sri Lanka was a strong supporter of FCTC to WHO. And signing the FCTC, we signed on 23rd of September 2003. The path towards FCTC ratification is a separate subject. You can talk a whole day what has happened, but I just mention here. After signing, after the approval by Cabinet of Ministers, we ratified on November 11th, 2003 as first country in Asia and 4th country in the world. So we are really proud to mention that we were the 4th in the world to ratify this very important public health treaty. And earlier, they look at the basic things whether we have a lot of tobacco control legislation under different departments. After that, we wanted to have a comprehensive law under Ministry of Health. But we had all pre-requirements and then the political will. and then we ratified. So by doing that, the review was done in Sri Lanka. Prevalence was going down, but slowly. This is something to do with the behavioral change. So you have to do a lot of efforts you have to take to decrease the prevalence. Not like other, like provision of health services, that is totally up to the Minister of Health. But this is, the individual should make it. So scope to be expanded, we realize, and we badly needed a comprehensive legislation, because whatever the strategies we did, we could implement, but the industry strategies like big hoardings and full-page advertisement in newspapers, as I showed, sports, cinema, everywhere. So for these things, the direct and indirect sponsorship and advertisement, we badly needed legislation. Whatever we did, other measures were going very well, but not this. So we took up, the tobacco control legislation. In fact, this was there was a draft and under the Minister of Justice earlier that we took over, Minister of Health, to pass that in the Parliament. It was a real struggle. Industry challenged us thrice, because when we presented that in the Parliament, and as I said earlier, being a party to FCTC was a strong factor. It was our requirement to fulfill as a party. And by that time, the 40 countries ratified. This treaty was entered into force after ratified by 40 countries. We ratified already in 2003, but it was entered into force, I think, 2005, later, when 40 countries signed. Right. And our law, there was a strong request by several parties to include alcohol as well, because, our tobacco control island-wide program was going very well, because we emphasized about second-hand passive smoking. That is why it was so strong, and alcohol is not like that when you drink, but alcohol is connected with many socio-economic repercussions, negative things. Therefore, alcohol also was included in our law. So ultimately, National Authority on Tobacco and Alcohol Act was passed in the Parliament, and it was challenged at the Court of Appeal. Before that, twice at the Supreme Court and then Court of Appeal. And ultimately, Ministry of Health won on behalf of nation's health. So we won the case, and this act was released in 2007. And that is to monitor all violations under this act, sponsorships, advertisements, sale to all the provisions in the FCTC, major provisions, and smoking in public places, and most importantly, all the hoardings, were eliminated overnight. When the act was passed, all the hoardings in the environment were removed. We did not do anything. It was all removed because it's the law, high penalty. So that influence was not there since 2007. Now, I want to show you how it was when I said in year 2000 it was around 25, the prevalence. We did National NCD Risk Factor Survey. In 2007 we did one. Although we wanted to do after 5 years, 2012 we could not do, but we conducted in 2015. So we compare. When you see percentage who currently smoke tobacco daily, it was both sexes, if you say 11.5, and it was reduced to 10.2. And 2015 it was 8,000 samples, 7,200 as I remember correctly, island-wide study. And we go by smoking by males, because female smoking is very much less. And 2007, which was 22.8, it was decreased to 19.9. And female, from 0.8 in 2000, it was 0.3 by 2007. 2015 is negligible, it is 0.03 or 0.2. So this was the case, and we are very happy compared to physical activity, inactivity. And also consumption of vegetables, fruits. Sri Lanka is a paradise of this, but people do not consume enough. So compared to those parameters, indicators, this was a very good decline. So tobacco control was good. It was significant in the results of NCD risk factor survey. We adopted WHO methodology, stepwise approach, if you know. Questioning, then measurements and biochemicals. So like that, stepwise approach. In 2007, we had 2 steps. Anthropology is questioning with the measurements, and by 15 we adopt all 3, even biochemicals. That means blood sugar level and cholesterol, all these things we did. And mean number of manufactured cigarettes, if you see, that also is reduced. Now, one can think why females 2007-13, those who smoked heavily. That is why. It was only 0.3%. But mean number of cigarettes is 13, more than the men. But because very small percentage who smoked, they smoked heavily. But now the situation is very, healthy. I want to mention, I could not put here, we were monitoring age at which they started smoking. That is also shifted to right. So from 17 years, it was shifted to 19 years, and it has come to 21 years now. That is a very good indicator. The mean age at which they take up for the first time. So that means the younger generation is, going towards right direction when it comes to healthy lifestyle. Right. Now, then, after implementing for about 4 years of law, our NATA Act, famous National Authority on Tobacco and Alcohol, we realized, when we did the review, we realized that we must go for other regulations. So first ever regulation under the Act, that is to prohibit sale of tobacco products without health warning. I think it was in the web, and it's a very big issue, and we had to face another industry challenge, legal challenge by the ministry. We had to, fight for nation's health. Originally, we wanted 80%, and we could not do that for some times. The same argument was taken up at the Supreme Court, like 2007, cases. But anyway, ultimately we could achieve this. 80% of pictorial warning is now implemented, and it is being implemented now in Sri Lanka. What was very important in Sri Lanka's constitution was because it's a legitimate in business anyway, and they argue about their right. But in the constitution of Sri Lanka, Article 14 and 15 provisions says even the fundamental right of something or entity can be restricted when it comes to national security, public order, and public health. So by that, together with FCTC, being a party to FCTC, I think these two facts were very important in winning the case on behalf of the nation. So we won the cases, and now tobacco control is well implemented in Sri Lanka. And then under the FCTC, first ever protocol was released and open for signature. That is also, as the first country in Asia, we are proud to announce that we have ratified on 8th of February 2016. Still not a single country in Sierra countries, Asia, could not do still. But we would like very much to do, and by developing as a country, we like to develop as a region. So we want very much other countries in the Asian region to ratify this and together, because the problem of tobacco is a cross-border issue. It goes beyond the boundaries of a territory. So as a region, we like to see the Smokeless tobacco. He will talk after me, and for there also we strongly support, and we have to be united to fight this epidemic. So that was the situation in advancement in legislation. Now I like to speak about factors influencing the success so far. First, the political commitment. That is a blessing. Whatever we professionals do, it is not to the fullest execution if the political commitment is not there. So we are very fortunate because the present president was Minister of Health earlier. So he fully understood. That is why our protocol was really ratified. And he was an award winner by the WHO DG's award. And also we have two ministers of health. The current one and the previous one was winners of World No Tobacco Day awards because of the efforts taken by them as politicians to give the real commitment to the area subject of health. So particularly on tobacco control. So political commitment is very important in any country. And national health policy. You know that Sri Lanka has a state-run health sector. We give everything free to the consumer. And if you take the country, in every 4 kilometers, you can get some level of care. Maybe it is primary or secondary or tertiary. At least central dispensary you can come across when you go anywhere, any direction. Within the 4 kilometers you can get. So, provision of health. We have achieved many quantitative indicators as far as, developed countries in the world. We are bleeding in many of the indicators in the region, but we are good as other countries in other regions. Now we are heading for quality indicators. So controlling tobacco will also it's not just numbers, but it will really improve the quality of life, and we can really prevent early deaths, preventable deaths. It's the most preventable cause of death. And Sri Lanka's number one killer is cardiovascular diseases. Since 1996, for consecutive years, cardiovascular diseases is the leading cause of deaths in Sri Lanka. For what about 30% is contributing this factor. So that is why worth intervening risk factors. So good national health policies there, prioritizing health, and prioritizing the subject, and not only quantity but quality. And multi-sector involvement led by health sector. With all due respect to other sectors, when health is leading, things are happening very fast, I must tell. Not because of I am a health professional, but I can remember, as I mentioned earlier, initially for the first 2-3 years, we are giving funds, even the funds we have to give to other sectors to start a program. So then by doing that, they realized, and now they are on their feet. But initially, it's like, we must vigorously engage. So that is, I think that is the case in most of the areas. But so multi-sectoral involvement led by health sector. So that's a strong factor. And strong promotion and prevention measures. Early behavioral change was our really motto. So we hit, even the risk factor occurs. Before the risk factor occurs, we wanted to intervene. So those are the factors really influencing the success of Sri Lanka. And what is the way forward? We really feel that we have not done enough for secondary prevention. We have only one quit line for Sri Lanka. We must admit our deficiencies also. And we want to take remedial action for what is not done adequately. So we have only one quit line. I can see some other countries, they have a lot of lines and lot of help. So we must help the smokers to quit. That now we have taken up that line, secondary prevention. Services to the affected. Not from only one center. So we have medical officers appointed for every district, focal point medical officers to look after non-communicable diseases. We have focal point MO. And look after mental health, we have focal point MO. We have 25 districts in Sri Lanka. Administrative 24, but health district we have 25 and 9 provinces. So we have those focal points, and we have clinics everywhere. Mental health clinics we have, and we have healthy lifestyle clinics. It's centers we call, where people can go and screen for their body weight, blood pressure, blood glucose, cholesterol. When it is voluntary, usually the female participation is significantly higher than male participation. That is reflected in results also, survey results. So we have to promote for more men to visit these clinics. And we have realized that now self-referral is also coming up to these centers. And also we have from another directorate from youth, there's youth-friendly centers in hospitals. So youth can go. So now the smoking among youth is much, it's very much, we can say that nothing, but maybe minimum compared to earlier. but we must maintain the status and we must improve. So those centers are there. So women clinics also there, the primary healthcare worker is there, they are very well educated, so they can refer to the relevant clinic or center. And one quit line is operating. And intervene smokeless tobacco. Compared to other countries in the region, we are less but not so okay. We must, because about 26% still it's being used, but the trend is good. Now younger generation, they don't go for this because earlier there were some smokeless tobacco, it's giving in a packet like this barbul and other things in provinces they used to promote among school children. Now we are vigilant and school authorities are vigilant, and I think we have to strengthen our control measures as we have done for smoking. Smokeless tobacco is also a problem, so we have to focus our attention. So this is why the second prevention of smoking and intervene smokeless tobacco. And also strengthen the law further. We are going ahead with plain packaging and prohibition of this single stick, sale of single stick. That will yield good results. So we want to strengthen whatever the existing measures in future. So these are the three major measures we are heading for. Without in nutshell, in a short form, this is what we have done. Our progress is a bit slow for us when we review, but it's steady. So it's a long journey, and it's a long journey to go, some more to go, not yet, but we are happy for whatever we have achieved, and we will strengthen further to achieve this nation free of tobacco is our, objective. One day it should be like that. So thank you very much, and I wish you all a pleasant day. Thank you.
Thanks. Thank you, Dr. Somatunga. It was a fascinating talk, and I must congratulate you, of course, for the first ratifying country for FCTC, but also for the illicit tobacco trade. I think it's a great achievement because it's the first country in Asia, although none of that surprises me because, to be honest, Sri Lanka is seen as a beacon of light in Asia. I'm originally from Pakistan, and I know that a few years ago there was a Lancet series published, and there were two places in Asia that were highlighted as like they've achieved so much with limited resources, and one certainly was Sri Lanka, the other was Kerala in India. So I think this certainly doesn't surprise, and I think for all of us it's a lesson that what could be achieved even with limited resources, you can have the really high standards and the highest indicators in health. So congratulations. I'm glad that you mentioned smokeless tobacco because that is the topic of my talk, and I'm very grateful to Dr. Bhattacharya and Professor Atkin for inviting me to the seminar. The reason I'm interested in smokeless tobacco is, I'll just make that obvious. How many people know that there are about 1 billion smokers in the world? How many people know that in total there are about 1 billion? Yeah? Nobody? Nobody knows? Right. Maybe one person. 1.2 billion tobacco users, yeah. And out of this, 1 billion smokers. But I think very few people know that smokeless tobacco is actually consumed by almost a quarter of tobacco users in the world. So it's a global problem. I'm going to focus my talk in South Asia, where basically 85% of smokeless tobacco users live. But really, it's a global problem. And I'll be making references to global use of smokeless tobacco also in the UK and in Europe, just for a comparison and for reference. So just before what is smokeless tobacco? So basically, smokeless tobacco is not a single product. There's just a range of different products, and they contain tobacco that are consumed without burning through the mouth or nose. And I've just put these pictures out just to show you the whole range of different types of products that are consumed. So on one hand, on this side, there's a Swedish snus, which is again consumed orally. And then in the middle, there's a product called pan, which is again very popular in South Asia. And on the other end, there is another product called gutka, which is usually sold in packaging. I'll be talking about these products more. In my talk, I'll cover the diversity of smokeless tobacco products. I'll be talking about the prevalence of its use, the harms particularly to health caused by smokeless tobacco use, and the control measures. So I think the first thing to say about diversity, that smokeless tobacco products, as I said, it's not just a single product, and the different smokeless tobacco products carry different risks. And that's why it's very difficult and actually quite challenging to have a common policy, because a combustible cigarette that contains tobacco is a combustible cigarette wherever you buy it from. So I think it's easier, relatively easier, to form policies for combustible cigarettes. But if smokeless tobacco products, which are sold in so many different varieties, all the way from custom-made products to packaged products to different kinds, then it's just very, very difficult. And it's not just the way they're sold, but the way they carry risks. So why does that matter? Why the difference matter? So I know this is a global health history seminar, and I shouldn't be talking about chemistry, but if you would allow me to indulge, I'll just say briefly that different products have different levels of pH. The products that are more alkaline, so higher the pH, they are more carry high risk because that increases the absorption of nicotine and other carcinogenic or cancer-producing chemicals. So the content of nicotine is important because, as you know, nicotine is the addictive substance within tobacco. So therefore, the higher the levels of nicotine, the more addictive that substance is. By the way, nicotine is not the one that causes cancer. It's the other carcinogens, such as tobacco-specific nitrosamines and several other arsenic and heavy metals and other compounds that leads to cancer. So how that changes from one product to another product, it depends on what tobacco plant you're using, how that tobacco is processed, what other things are added to it, how that is consumed, and what is the policy context in which these products are consumed. So just for reference, I'll mention this, that Swedish snus, which is a highly regulated product, so it's a smokeless tobacco product, but in fact, it is almost considered as harmless. In fact, in Sweden, most of the tobacco-related deaths have come down quite significantly because people have either stopped smoking cigarettes or switched to this smokeless tobacco product. Now, clearly, that makes it quite challenging when we're talking about smokeless tobacco use at a global level, because clearly there are several people who are proponents of using Swedish snus as a harm reduction product. And I have some sympathy with that, because if you look at their indices in terms of the various cancer-producing chemicals, then those chemicals are much, much lower. And in fact, these are certain industry standards that are implemented by the government and regulated by the government to try and keep the cancer-producing substance to an absolute minimum. So this is clearly a much, much safer product that has been used in Sweden and other Scandinavian countries, but for strange reason actually still banned to be sold in EU. But we won't be talking about that. We are talking about and more interested in the products that are used in South Asia and also in Central Asia. So this is another product just on the other extreme, Naswar, not regulated at all. It's mixed with lime and ash, and which gives it more of an alkaline flavor. It's very popular in Central Asia, but also popular in South Asia, including Afghanistan, Pakistan, and also northern parts of India. And it's placed between lip or cheek and gum, and it's kept there for about anything between 30 minutes to an hour. And as you can see, the more it stays in the mouth, the more cancer-producing chemicals are absorbed, and therefore are putting that person at risk. This is another product in Africa used in Sudan, using fermented ground tobacco mixed with sodium bicarbonate, which is another alkaline product, and it's also highly toxic and addictive. But we're more interested in the South and South Asian products. So there are three varieties of those. One is user-prepared. User-prepared means that this is prepared by the user themselves. And for those of you who are from South Asia, I don't know if you had any experience, but certainly my grandmother had this box in her house where anybody who's visiting the house, so why we offer a cup of tea in England, in Pakistan, my grandmother would offer pan. So she will open that box and she'll take the leaf out and paint it with white ash and then a brown paint, and then put some tobacco in and put some betel nuts in, and then roll it up and serve. Certainly we were intrigued and we were very interested as children, and we wanted to have it. So thank God that she didn't give us any tobacco in it, but we certainly had the taste. And the reason she didn't give it, because she said you will get dizzy. So it wasn't because the tobacco is harmful or anything like that. She just said you will just feel a bit dizzy, and therefore it's not a good idea. So anyway, even for that reason, I think it's good that I didn't use any smokeless tobacco. So that is custom made, and that is served in houses and kept in houses, and I think it's very popular in Bangladesh. When somebody's visiting, that's the kind of a protocol, a customary protocol. It's also served in weddings. And we were talking earlier about the culture, and that's the sort of cultural association with tobacco use, which I think is very different. So it's very different for people to understand that, because cigarette smoking is no longer a social behavior anymore in the UK, for example. It's an isolated activity. People are using cigarette smoking usually outside restaurants and bars in isolation, standing on their own. But that is not the case with smokeless tobacco in South Asia. It's very much part of the culture, the celebrations, even the religious celebrations, weddings, and social visits. So that is custom made. So the other one is custom made. So you go to a shop, and there are lots and lots of pawn shops in South Asia, and then they will put different products out, and as you say, they will mix different things, including tobacco, and they serve you. So that's custom made. And then you've got manufactured products, local and small scale, and also produced at large industrial scale. This is also, by the way, these custom made products are also available in the UK. I don't know if you're from Yorkshire, so you must know the most famous Asian restaurant in Yorkshire, Mumtaz Restaurant in Bradford. Do you know how Mumtaz Restaurant started? It started as a pawn shop. So it was Mumtaz Pawn House. And so it turned into a big restaurant, and I think they probably still serve pawn, but not like that. So this is what we've been talking about. One of the products. It's pawn. So as you can see, let me see if the laser works. So this is the leaf. By the way, this is not tobacco leaf. This is betel leaf. And on the betel leaf, there is this white paint, chalk. And then there's this brown chemical called caoutchouc. And then this is tobacco. And this is areca nut. So areca nut in itself is also a cancer-causing substance. And what it does in this situation, it causes a little aberrations in the mouth, and that helps to absorb tobacco even more. And obviously slate lime also helps to absorb tobacco even more. So then it's wrapped up, and as you can see in its full glory, with all different colors and all different flavorings and everything, is served in a street in Lahore. So that is a very, very popular product, but that's certainly not the only product that is used. Okay, so This is, again, comparing different products. And again, I won't go through each and every product, but you can just quickly see that products that are used in South Asia have got a very high level of, these are the carcinogens, a very high level of carcinogens. And if you compare that to products that are used in Scandinavian countries, they are pretty much controlled. The pH is low. Here, the pH is as high as 10 or 9.8. So, and the nicotine levels are quite high as well. So these products are used in South Asia and also in other countries with obviously potential to cause damage. So what about the prevalence of these? I think I should come out from the, yeah, thank you. So smokeless tobacco is consumed in more than 100 countries. In fact, the latest figures shows that it could be up to 140 countries. So it's certainly not a problem of South Asian countries. It's also a problem globally. But clearly South Asian countries top the list. As you can see, within females, in Bangladesh, almost a third or 30% of women are using smokeless tobacco products. Now that means every third woman is using smokeless tobacco. And again, among males, almost every other person in Myanmar is using smokeless tobacco. Nepal is also very high, Bangladesh as well. So these are some of the maps on smokeless tobacco prevalence for females. And the darker the shade is, the highest the prevalence is. And again, South Asia, as you can see, with lots of dark colors, and also parts of Africa. And this is the male prevalence, again, showing dark colors and in Asia and parts of Africa. So I've got some figures from Sri Lanka, which are from the STEPS survey from 2015. And it shows the smokeless tobacco prevalence. You mentioned 26%, and also among males, it's about 15 in both sexes. Among males, it's 26, and females is 5.3. So I think you're very right in suggesting that this is an area of further work, and further efforts need to be made in controlling smokeless tobacco. So what are the health risks? Why are we worried about smokeless tobacco use? It is the number one, so it links with oral cancer, and oral cancer is the number one cancer among South Asian men in the world. In the UK, oral cancer risk is also very high among South Asian females and is higher than general population. In fact, 50% of all oral cancers in South Asia happen because of using smokeless tobacco. And as we know, 85% of all smokeless tobacco is used in South Asia. So there's a very strong link between smokeless tobacco and cancer. And this is just for some epidemiologists to see that the risk of oral cancer is actually 5 times more if people are using smokeless tobacco. And the studies that are from South Asia actually put the risk up to 10 times more, while studies from Sweden and Norway actually does not show any risk. So as you can see, there's a huge variation between the risks of oral cancer. And it's not just oral cancer, it's also cancer of the throat and esophagus. There's some evidence of linking with cancer of the larynx and pancreas. There's strong link with mortality or deaths in coronary heart disease, and links with oral disease, and also links with poor birth outcomes. It also leads to a immense disease burden. So this is a very conservative estimate that shows that almost 2 million disability-adjusted life years are lost because of smokeless tobacco. And I think we estimated that overall 500,000 deaths could be due to smokeless tobacco in the world. But 85% of that is in Southeast Asia. So what is the policy background? So this is the sort of second half of my talk. As it was mentioned by Dr. Somatunga, that Asian countries, South Asian countries have signed up to the World Health Organization Framework Convention for Tobacco Control. So this is the lever for the countries to actually implement policies against tobacco control. We did a literature review which shows that Framework Convention Tobacco Control Act articles should work to reduce smokeless tobacco just as they work for cigarette smoking. So if you increase taxes, for example, just like increasing taxes reduces cigarette consumption, similarly, it should reduce smokeless tobacco consumption. And just like graphic health warnings work for cigarette consumption, reducing cigarette consumption, it should also work for smokeless tobacco. But, and this is a big but, their implementation lags behind for smokeless tobacco compared to cigarettes, and that is the problem. So when we look at the policies, the bar is much lower for smokeless tobacco. Very few countries regulate smokeless tobacco contents. Smokeless tobacco taxes are far less than taxes on cigarettes. In fact, if you in South Asia, if you compare taxes on cigarettes and taxes on other smoked tobacco products and taxes on smokeless tobacco products, unfortunately, taxes on smokeless tobacco products are the lowest, which means that it should be high or just as high. The other risk is that people can switch. If there are differences in tax between different tobacco products, then you increase taxes on cigarettes, then people can stop smoking cigarette and switch to smokeless tobacco, which is just shifting the risk from, let's say, lung cancer to oral cancer. Now, we don't want that. So one recommendation that I think almost anybody in tobacco control makes is that the tax rise should be standardized across and uniform across all tobacco products. Similarly, the health warning requirements are less strict than those for cigarettes. And when you look at the implementation, the compliance is very poor. So as you know, there's a ban on tobacco advertising, promotion, and sponsorship, but smokeless tobacco products are still promoted in South Asia at point of sale and also via media. So World Health Organization have got a surveillance system for seeing whether the countries are actually implementing or following framework conventions. So what they have is policies, and they assess consumer behavior by doing surveys, and we also have the health outcomes. But as those of you who are familiar with the context in South Asia, and in fact most low and middle income countries, that making policies is one thing and implementing them is another thing. And how do we check implementation? So we are doing some work here in York, actually working with not just in the UK, but also in South Asian countries. We're looking at the supply chain, because that's where most of the implementation happens or doesn't happen. So that includes point of sale vendors, wholesale retailers, the manufacturers of smokeless tobacco products, and the raw tobacco that they get from retailers and the tobacco farmers. So we're looking at where at this supply chain there is actually a gap in terms of implementation. And from the preliminary work that we've done in Bangladesh, Nepal, and Pakistan, we've looked at who is paying taxes, who's got the license to sell or produce or distribute smokeless tobacco, whether people are actually implementing health warnings. And as you can see at the bottom of that table, that almost half of them have got some health warning, but actually if you look at that health warning, it doesn't make much sense. And almost no products have got any pictorial health warnings, and certainly not complying with the 80% recommendation that it should cover 80% of the product. Product displays are still advertised and promoted in shops, and incentives are offered to the sellers. And actually 1/5 of smokeless tobacco products were smuggled without carrying any address. And I think it's good that Sri Lanka has signed to this illicit tobacco trade protocol. So I think it'd be interesting to see how that works in terms of smuggled products. I don't know if there are any smuggled smokeless tobacco products that are imported or they are brought into the country. So I think that would be good to see that. So this approach can tell policymakers who is in the supply chain is currently taxed and regulated. It indicates a proportion of smuggled products, the extent to which these are sold with health warnings, content information, and manufacturers, and how they're advertised, and once incentives are built into the supply chain, and whether there are any sale restrictions. I would like to mention that smokeless tobacco cessation is a very, very important area. The work that we have done shows that people are heavily addicted, in fact, even more addicted to smokeless tobacco products than you find in cigarette smoking. Very difficult to break the habit. And it's not just because of the physical addiction, but also because of the socio-cultural associations with smokeless tobacco. So we've been working and developing various products, including some apps to help people to quit. Last but not least, I would like to mention our new program of work. So we've been very fortunate in New York that we've been funded by the National Institute of Health Research to establish a group that would address smokeless tobacco use and build research capacity in South Asia. We'll be working primarily with the first institutions in the 3 countries, in Pakistan, Bangladesh, and India. But in the next phase, we'll be involving Sri Lanka, Nepal, and also Myanmar in this group. At the moment, it involves 20 scientists working in 4 different areas. So the areas that we are interested in working is youth. So we will be establishing a cohort of young people in schools, and by surveying them on a regular basis, we'll be seeing the effect or impact of different policies in different parts of South Asia and how that influences their attitudes. We'll be also doing the supply chain, or looking at tobacco sellers and how policies are influencing tobacco sellers. We are very interested in to assess the economic burden or economic impact of smokeless tobacco use, and also not just that, but how different policy measures could actually reduce the impact, and what would be the return on investment of different measures, giving that option to the policymakers. And last but not least, we'll be also working on tobacco cessation, smokeless tobacco cessation. So I'm very excited about this. We've been funded for 3 years in the first instance, but I think this work, I'm hoping that it will carry on for a number of years until we've at least come to the same situation with smokeless tobacco as we have with cigarettes. Yeah, I mean, I would really welcome that other countries also join this initiative. As I mentioned, that my first invitation would be to Sri Lanka, Myanmar, and Nepal. So thank you very much.
So I'll go to the audience in a second, but maybe to begin with, we can perhaps have just a short kind of conversation amongst ourselves. And if you don't mind, I'd like to kind of start off with a question that struck me, and that is to do obviously with the kind of the reaction, the kind of cultural reaction to the smoking bans and control on for the regulation of tobacco in Sri Lanka. And I don't think you touched on this, but what was the kind of popular reaction to some of these measures that were implemented by Sri Lanka? Because obviously in the European context, the popular reaction was often very problematic. People didn't want to quit smoking. People didn't like the idea that they weren't allowed to go into bars and continue smoking. So I'm just wondering if you could say a little bit about the kind of popular reaction to the rules that were introduced.
Actually, Sri Lanka's setup or culture is a little different because it's state-run health sector. So people are with the health. People are health sensitive. There was a definite gap, and there is still existing definite gap between what you know and what you practice. So somebody should be there to, emphasize that, yeah, there's a gap. So therefore, people knew that they are doing harm for themselves. And when it was elaborated, they really accept. There was no problematic, unless otherwise there's the industry influence. So because if you analyze the 3 cases, the 2 directly filed by industry, but 1 was retailers. So that is not their, maybe obviously their own intention, but behind that, somebody is influencing for them to file a case. Otherwise, it's obvious that whose intervention is. So therefore, when we release, and we always connect that to the health of the nation, and those who smoke, they don't want their children to smoke. So generally they are health sensitive. Even when we conduct surveys, unlike other people now, the soap industry, shampoo and other, they go to their doorstep and ask questions, and it has become a problem to them. But when somebody is going from the Ministry of Health or health worker, they accept usually. So they are health sensitive.
And
somewhat.
would you say that, because you mentioned also briefly that the media was kind of behind you, or that you had, you had the media to thank. Was that also, was there generally a sense that the media was supporting this activity?
Media was really supportive. So we had a close, coordination with them. We had very frequent media briefing, very frequent media seminars. So they gave a fullest support, and we are really thankful to them. They educate there are, when you take the tabloids, the newspapers, there are different kinds. For women, there are different papers. Usual regular things are there. For youth, there are papers. So all, irrespective of the type of print media, they gave their fullest support. Maybe that is also a fact, but generally people are health sensitive because of when they fall ill, they can go to any of the hospital and take care, and they don't ask even where you sit, where you live even, so people are so connected with the health sector. That is why they accept what we really do. And maybe the other thing is because of our primary healthcare infrastructure. So there's a person who goes from house to house always. So they are with the health sector. So I think it was a reminder like that what they do is not correct. And some really wanted to quit. Anyway.
So maybe I can ask you, Kamran, a follow-up question to that. Do you, so if we accept that the kind of successes around smoking tobacco, were that they have been these successes, these strides forward. Do you see the same kind of complicitness on behalf of the consumer when it comes to smokeless tobacco, or do you think that there may actually be more backlash from the kind of general public or even the media when it comes to these kind of more indigenous products, these kind of things that are more culturally interwoven into people's lives, that they transcend perhaps just the product, and they are much more to do with social interactions and the way people go about their kind of their daily lives?
I think they're certainly going to be challenging, but I think the approach may need to modify. I'll just give you an example. So in the UK, we've been working on, for the last 16, 17 years, we have a very good smoking cessation services, which are basically based on an individual counseling. So an individual person goes to a smoking cessation specialist, get advice, and you've got very good results. Now, when we try to do that in Pakistan, I think it didn't seem to work because this was a family behavior. It's not an individual behavior. It was very much ingrained in the culture and cultural context. So we realized that we have to modify it. It has to be a family or a community-based intervention because the same approach is not going to work. So I think we need to, as we were talking earlier, and almost to the cliche that cultural contextualization or adaptation needs to happen for almost every intervention, but even more so for smokeless tobacco. But I have no doubt that I think the actual principles of Framework Convention for Tobacco Control are right, and they need to be implemented. We just need to get a bit more sophisticated how we do it in different countries, and especially in smokeless tobacco.
Lakshmi, do you perhaps want to say a few words about how the Sri Lankan government is beginning to tackle this outstanding issue of smokeless tobacco use? You were saying it's kind of something you want to focus on more. Do you want to say a little bit more about that?
Yeah, we have a plan. Yeah, like we integrated tobacco control in the healthy lifestyle. which was, very effective. So we want to go forward with keep your city clean and at least first to prevent, in public places, spitting and other. Now the trend is, they feel very guilty to, because that will affect the cleanliness and tidiness of the place. So as he very correctly said, now it's mostly restricted to family, their own premises. So we must use changing agent of children. And earlier it was, earlier before 2000, in the buses, although there was a law, some people used to smoke. When we really, strengthen the people's capacity, now women started say, you can't smoke in the bus. Children started saying, how can you harm us? So like that, you have to, the other party, you have to strengthen their, the right should be given to others to intervene. So that way, we want to integrate into something more important. Then naturally, it will go off, I think.
Behavior change through guilt.
Behavior change, and that we want to, it's not accepted thing. Like in clean and society whose concern is tidiness and cleanliness, it is obviously not an accepted thing, this smokeless tobacco. So that way, and I can see that even youth now, they are very fashionable, becoming fashionable and very clean and, going with the style. So we have to link that fashionable and cleanliness and, to give away with this bad habit. Our problem is somewhat low socio-economic strata, like masons, and carpentry. So among these workers, we have observed that because they, without going to vocational or higher studies, they take up and mining, gem mining. So at very early age, they go for these occupations. So there's a trend because they go with the trend, that society. So we have to intervene particular strata. I mean, like when we launched tobacco control in Sri Lanka, we were focused on estate community and urban slums, where the national statistics level was something 25, but in estate community it was more than 50, and urban slums it was 40. So like that, although the national level figure is less, but there. So you have to intervene this particular communities or strata.
And is I mean, this might be a bit of a difficult question to answer or a sensitive question to ask, but is the level of commitment, do you think, by on behalf of the government as strong for smokeless tobacco cessation? I mean, do you still have the same kind of political backing that you seem to clearly have with...
Definitely, because it is not accepted thing, chewing and tobacco. We never say that smoking is good and it isn't, but both are at the same level and same government commitment, I mean, in political government and policy can be expected, I think.
If you, I mean, on that question of political commitment, I mean, you said that at the highest level of government, your president at the time had been previously a minister of health. Is that right? And consequently, he brought with him some of those concerns and some of that knowledge. But nevertheless, he could have chosen to focus on other health challenges. So, do you know if there was a particular reason that that person was so keen on tobacco control? I mean, is there another kind of story behind that?
I think because he was in the Ministry of Health, and during that period FCTC was released, which was instrumental. We were a party, and we were going forward, you know. It was not so addressed, the issue. So one by one we address all our prioritized issues. So tobacco control was a priority by the Minister of Health. So obviously Minister of Health is involved, a part of it, and they gave their fullest commitment. Anybody can see that by intervening this, we can yield good results. And in the context of state-run health sector, why should we spend so much money on sophisticated investigations, especially for NCD investigations are also very costly, and government spend on this, and most importantly, consumer or the individual Sri Lankan person is very important to us. Their health is very important, and their life expectancy is very important to productivity of the country. So we prioritize health of the nation.
Okay. So your Prime Minister saved your country a lot of money with
yeah, so
with
we
that.
can utilize this money for genetic or these things we we can give optimally. Those days we used to say, even I myself, though these genetical, these like thalassemia and other, now we are taking up, although less number compared to cardiovascular events, that's sickle cell, thalassemia. So we can divert our resources for optimal care for those affected. Why you go for bad behavior and get sick and use people's money when you can just give up your respect. So this is our that is the moral behind that. So we want to go for stem cell transplant, other things. So these are costly. So government can fully concentrate on these things. When preventable, these are preventable. So we go for other halfly addressed sometimes maybe. So we are now taking up other things too.
Very good, thank you. Just before I go to the audience, I have one more question, just because when we were talking earlier, I kind of was hearing some of the work that you were doing, Kamran, in relation to kind of community leaders and bringing on board people with perhaps a strong influence on various communities in relation to smokeless tobacco cessation. Do you want to say a little bit perhaps about that and the importance of those kind of voices, and perhaps I don't know if one could put a number on that on the kind of multiplier effect of individuals like that, but it'd be quite interesting to know a bit more about that dynamic.
So as an example, I think we're doing some work in Bangladesh where we're using faith leaders, in fact mosques and imams, to be the advocate for creating smoke-free homes and smoke-free environments in the community. And the inspiration of that actually did not come from a university or an academic or any book. It actually came from faith leaders themselves. In fact, I was working with a community, and the faith leaders themselves came forward and said, why don't you teach us about smoking and harms of smoking, and we can work in the community. So I was a bit skeptical, but then I sat in one of their sermons, and the way they talked about it, I could never do that. I could only talk about health harms and the effect on lung and lung cancer and so on. But the way they talked and they articulate and the way they spoke was much more, I think, powerful. and certainly I could see that the people. So I think that was the moment when I sort of started working on this area. Now we've got a major trial going on in Bangladesh where we're using imams to use their sermons and their influence within the community to try and shift some of the social norms around creating smoke-free environments, in creating smoke-free neighborhoods, smoke-free homes. So it's still an experimental work, and we very much like to see how that progresses. So I think we've got a grant from Medical Research Council to do this work over the next 3.5 years. I think one of these interesting things that we're doing is actually we're using the religious scripture and linking that with health promotion messages. It's quite innovative work, and it's done between behavioral scientists sitting in the same room with the scholars, the more religious scholars, and coming up with text that links health promotion with religious scripture. And we're going to use, or we have used it to develop a curriculum for religious faith leaders. So let's see how that goes.
That sounds like a very sensitive type of area, because obviously I'm sure no religious leader would want to see their kind of holy scriptures to be purely seen as vehicles for health promotion, as it were. So I imagine there's some very delicate conversations that have to take place.
Yes, yeah. So we've been working for a year and a half with the Imam Training Academy in Bangladesh to come up with the right sort of messages. And because we're not theologians or anything like that. So we just have, so we basically left it to them. And in the end, we were just testing whether this would convey the message that we want to convey in health promotion and health behavior. But it was pretty much what they came up with. So they came up with the scriptures.
And as part of that, you're kind of planning, or you have an evaluation that where you try to capture whether or not the effect, I guess, that's...
Absolutely. So we'll be recruiting 1,800 households and in communities around Dhaka. Working with 45 mosques. It's a randomized control trial. It will take 2 years to see what effect that has.
I want to add something.
Please.
For your second question, I really forgot that. Good that I... for same political commitment will be expected and definitely will be gained, because we have a culture in when we invite our Buddhist clergy, priest, we go with a bundle of betel leaves, and their arecanut and used this tobacco leaf, and we want to make this healthy pocket of this betel. And our president, the first one, the movement started with president was offering to the chief. We have 3 major groups of Buddhist clergy, and he offered without tobacco and arecanut event. And there's a very traditional and very old stanza where they describe this betel leaf and cardamom, cloves, these things, but there was no tobacco there. So we, quote that. See now, there was no tobacco in this. Originally, those very good old days where Lord Buddha was there. So it was no tobacco. So we are quoting that, and we want to make healthier betel somewhat the plate for offering. And he started that, and now clergy, priests are accepting that. And as an initial measure, we had some programs for them at the Ministry of Religious Affairs. We invited them and we offer them, and we make them aware that these are the effects of using this. And then we offer dana with much respect, and we hope that when they deliver sermons, they will spread the message. So this was our one way. So we already started, then President took the leading role in that.
Very good, thank you. So I guess over to the audience now. We have a bit of time for some questions, and please feel free to ask them. I can see a hand over there and here. And can I just ask you, do we have a microphone or no microphone? Okay, so what I might do, because I'm not sure it'll be picked up by the recording, is just kind of rephrase or try to ask the question again so that it's captured here by the microphone. But yes, please.
Thank you so much for presentation, both of you. And my understanding is tobacco control program in Sri Lanka is one of the successful public health measures or public health programs in Sri Lanka. So up to now, I think we have achieved a lot. But for me, there are some informal sector like non-smoke tobacco. It's up and coming area. And for that, we have some measures. But I suppose we need to be improved in a lot. Because it's really not a legal sort of a business in Sri Lanka in some areas. We can't really reach in that legal system. So I hope if you want to go beyond controlling of the tobacco, then we need to have some other strategies to overcome the smokeless tobacco use in Sri Lanka, especially in lower socio-economic strata. And it starts not at the school level. Now in the current trend is just after school. School leavers who are the people feeling only this smokeless tobacco. For that, I think we need to have some other legal and legitimate sort of actions to prevent it. That's my real personal comment, as well as I just want to know what are the current trends in what the Ministry societies going to be. The second thing is assessing the smokeless tobacco level in terms of supply chain. Sometimes it's not possible due to it's not a clear-cut sort of venture. It's a really underhand sort of venture. And I can say sort of it's like cottage industry, or it's illegally imported in the country. Therefore, we don't know what is the magnitude of the problem. And for that, I think we need to have some research. It should be rooted in a societal level to get the real data. And for that, I think Kamran's study is really based on that. And if you don't get a real picture on that, we go ahead with the assumptions. And when you put into the assumptions into a model, the results may be different. Therefore, I just want to know whether you have any other mechanism to understand the informal sector or the legal sector of the usage and the utilization of smokeless tobacco.
Thank you. So maybe if I just re-ask them again, and I think the first question perhaps is more directed towards you, Lakshmi, and I think it's a kind of expansion of the question around strategies. What other strategies are there that the Sri Lankan Health Ministry is thinking about in relation to dealing with smokeless tobacco issues? If perhaps I think I got that right. If you could expand on any other kind of things that the Ministry of Health is thinking about to deal with that.
Yeah, we are thinking of what we did earlier now. From the schools, there's a good trend that smokeless tobacco use is coming down. Especially urban areas, it is not accepted now. And periphery. So all zonal directors of educators, because they are aware on this very serious issue, and they follow up with the principals and the staff of the schools, because one good point is the additional secretary, higher level official from Ministry of Education is representing at the NATA board. So whatever we do the strategies together, we plan, and the school sector is implemented by that particular officer. So he's aware of all strategies we discuss and what is happening at WHO also, and as a party to FCTC. So it's very well represented there. And from youth, there's another person representing. So he's our focal point. The same strategies with youth clubs. We want to really educate, and our principle is illegal things are illegal. I think although as Dr. Tulamolla said, we must have very fine-tuned strategies. But one strong point is illegal things are illegal. I don't think that it will be so difficult as legalize vector in fighting with the legalized, industry, because these are legal. That is why this very comprehensive and strong legislation was needed, because already it is legal business, So this is somewhat illicit. So illicit things should be, handled that way, giving weight to that illegal nature of that. People should be lawful and health sensitive and mindful of their own health.
Then maybe the second question was for you, Kamran, which was about this question of the kind of the degree to which the whole scope of smokeless tobacco trade along the supply chain is actually captured. Do you have a kind of sense to what extent the numbers that one can gain access to are actually representative of the whole problem?
So I guess I started this work a few years ago because I asked a very simple question to some of the experts, and at that time I wasn't working on smokeless tobacco, and I asked this, that can you tell me what proportion of smokeless tobacco is consumed that is produced in the formal sector and that is produced in the informal sector, in the cottage industry? And nobody could give me the answer, because if you don't have the answer, if government doesn't know, then how are you going to tax, and how would you know that your tax is going to make a difference? Because you may tax the formal sector, but what about the informal sector? If that is 80%, then your tax measures are really ineffectual. So nobody had the answer. And then the reason why, because nobody actually tried to measure that. So we developed and tested this methodology, which basically starts with a very small survey of vendors, people who are selling smokeless tobacco, and then we do a snowball sampling technique in which we ask them, okay, so where are you buying it from? And of course, not everybody is going to tell the answer, but some of them do. In fact, 70% did. And then we ask them, okay, so where are you getting your products from? And retailers, wholesale retailers, then asking about manufacturers, then asking about raw tobacco dealers. So until the chain goes cold. So in that way, we were able to sort of at least get some sort of sense of the supply chain. And we've tested this methodology, and with the help of this new project, we'll be able to do more large-scale studies in at least in Pakistan and India, and also in Bangladesh. We also have an opportunity to test this methodology in the UK, because we also have a smokeless tobacco issue. So in fact, for us, my colleague is sitting here, he's working in 5 cities in the UK, including London, Birmingham, Leicester, Bradford, Leeds, where we are testing the same methodology and trying to find out where the supply chain is, just to get an idea and give policymakers some sense of how do you implement tax measures, how do you do different things. But if you don't even have the picture, then where would you start? So I'm not sure if I'll be able to capture everybody, but maybe at least get some sense of some better picture. We'll know more than what we know now, I guess.
Thank you. I think we had a question here in the middle.
Yes. So I noticed in both the presentations that there seem to be differences between women and men over either the number of smokers or the type of tobacco product that was consumed. And I was wondering what type of interventions, maybe in terms of health campaigns about how and where you present health messages, or which community leaders you approach, are sort of included in the way that people try to tackle these.
Thank you. So that's a really interesting question, I think, and probably certainly one for both of you. But perhaps we could start with you, Lakshmi. So, can you perhaps give an example or talk around this issue of gender specificity, as it were, in health promotion on this topic? Were there campaigns specifically targeted at men versus women, or how did you go about tackling this issue?
In our tobacco control, smoking, we did not target because our very minimal, numbers in ladies. So, but we never said it was targeting males. But we showcased the figures, the male prevalence, and together with females. So there was a difference. Otherwise, we never targeted only one specific sex. So it was island-wide full program. So even in this smokeless tobacco, I think, here the situation is different. Where they use the females are also engaging this, but majority are males, but still we should not be gender specific. I think health is for the individual, and that should be the country without restricting to one group, I think. So we have never said, and this even other programs, when we said that we must target children, women, and there was no big support towards separate programs. It should be, we are an island-wide, a national program.
Kamran, what about you? Has there been a kind of gender lens on some of the work that you've done?
Yeah, I'm really glad. I think in relation to the work that we're doing, I'm really glad that you asked this question. In fact, I have to report back to my funders in 6 months, answering 2 or 3 of their questions. One of this question is exactly what you said, that how you're going to approach the differences in culture in relation to gender. So I guess, we are really at the start of this work. For example, in case of Bangladesh, where we know that almost a third of women are using smokeless tobacco, and we know that if we go by, for example, the mosque approach that I just explained, that is not going to work for women in Bangladesh. So for them, maybe there are community health workers who are female, like Siddiqi, who work with in ladies during pregnancy and afterwards. So clearly we got to come up with those kind of approaches. I can't give you a definitive answer. It's something that we need to consult with our stakeholders in those countries, and then within a period of 6 months, I think we got to then present this to our funders. But I think it would be, so while I agree with Dr. Somatunga that I think in terms of the overall policies, it should not be gender specific, and when it comes to tax or smoke-free places and so on, but some of the health promotion approaches certainly should be modified as in relation to where, if there is a particular approach that we can use which might be more effective.
Any other questions from the audience? Yes, please.
I have a question about, again, about the supply of the, and I can see that some of them, or at least the smokeless ones, are perhaps, small vendors, but I wondered where big tobacco is in any of this. Do they make smokeless tobacco products, and what was their response to any of the efforts that you were making in Sri Lanka? What's the debate around tobacco supply?
Yeah. So the question from the audience is around tobacco supply and how big tobacco, so the tobacco industry, is kind of is impacting on that discussion. It's obviously that story is quite pronounced in the tobacco smoking, But I guess, perhaps you could say a little bit about how in Sri Lanka tobacco companies are influencing the smokeless tobacco discussion.
Smokeless tobacco discussions, we have not yet yield anything, otherwise industry influence is always there. That is Article 4.3, in the FCTC, because they were heavily engaged in the, despite the law, this indirect advertising, sponsorship, etc. As far as smokeless tobacco, we don't have any, collected evidence yet. We must launch a very focused program and see. Anyway, we must monitor any influence that comes.
I guess the industry is a lot more fragmented. The smokeless tobacco industry, it's much more kind of, as you were saying, the kind of in the informal sector, cottage industry. There isn't that same kind of lobbying power that is associated with the kind of big brand tobacco that we have with smoking tobacco. Do you think that's fair to say?
That is fair to say, but I think in India certainly we haven't got a lot of data, as Somatunga said, but I think in India certainly the big tobacco is moving into smokeless tobacco industry.
Okay.
And they're trying to at least capture the sort of big areas where they can influence. So I think, that's part of one of our questions for our research and supply chain is actually trying to understand the proportion that is linked to big tobacco as opposed to linked to informal sectors and cottage industry.
On a slightly kind of separate, but I guess connected note, the kind of tendency within Western countries, obviously, for smokers to switch towards vaping and that kind of activity, is that beginning to find its way into South Asian or Asian markets as well? I mean, is that a thing? Or not? Yeah.
So I guess from the surveys that have been done, it's less than 1%. So it's certainly not on the same scale as US and the UK, the electronic cigarette use. So it hasn't become a problem or an issue or something that. But I think a lot of us are watching carefully.
Because obviously that kind of health argument that you were alluding to with snus is also being made in relation to vaping, that it's, as it were, a healthier alternative or a way of weaning people off tobacco use. Any other questions from the audience? Yes, I see a tentative hand.
Yeah, this is a tentative question. I'm just interested in, I'm really interested in the behavioural change element of the tobacco campaign. And I was just wondering what kind of successes of that in the Sri Lankan case have been transported to other policy areas? Or is it kind of confined more to the tobacco area, or is it filtering into other ways of dealing with health issues or even foreign policy issues?
Another great question. So the question is around lessons learned, I guess, from the tobacco control and the tobacco behavior change initiatives in Sri Lanka, whether or not there have been any opportunities to use that in relation to nutrition, for instance, or other public health challenges, other public health campaigns. If there's been any kind of lessons learned where the government has kind of said, okay, this has worked really well with tobacco, perhaps we can use these similar behavior change ideas in other areas, public health areas.
This was the strongest, most program when it comes to the behavior change, because actually, other public health campaigns or programs are always with animal vector, and which is no behavioral component is involved. Like we reached elimination of malaria, then the filaria is coming now, elimination, and leprosy we eliminated 5 years before the WHO target year. So totally medication and It's not something to do with the behavior. So that is why, but how to reach out the population is a good lesson from tobacco control. The coordinated action, and multi-sectoral engagement, and also working at the community, grassroots level. So these are basic public health principles we really implement from public health basic principle to tobacco control program. So there's a distinct difference between other programs. Others are communicable. This is somewhat communicable, but with the industry vector, but sometimes something is different.
Should I add something?
Yeah, please.
So within non-communicable diseases, I think the biggest, most effective strategy in tobacco control, which is, as you know, tax increase, that has changed consumer behavior.
Right.
So that's been used in alcohol control and also within sugar. So you know that increasing taxes on sugar, increasing taxes on, it's been promoted. I'm not sure many countries have adopted it yet, but I can see that that's going to happen.
Yeah, there's a distinct, difference. Now, food can be made healthier, but can smoking made healthier? No, that's gospel truth is it's a harmful agent. You should not alter, but to prevent. So same principle does not apply. I want to ask a question because from your presentation, I waited until other people asked. You showed in Nordic countries the smokeless tobacco. Is it among migrant population from Asia? Because that was confined to Indian region. Because we have never heard that originally Europeans used to take this. So maybe among them, because quite a lot people have gone there and work and so it is very interesting to note. You mentioned Norway and another country, Sweden, lot of Asian. So
no, it is actually a general population, and a fifth of Swedish population is using smokeless tobacco.
1/5.
1/5 males. So it's actually a very Swedish thing to do, apparently, and it's indigenous, but it's heavily regulated. It's really, I think, a good example of how you can regulate tobacco to make it less harmful and even reduce harm.
And snus is also, I think, highly gendered, isn't it? I mean, you as you were saying, it's amongst males. You probably, I don't know, is there even any statistics on what percentage females use smokeless tobacco or snus?
There's certainly one in my slide, but I can't remember it.
Yeah,
It's less than theirs.
I can't imagine it being very high. It seems
very. I won't give you a number because I can't remember it.
Yeah.
But it's certainly lower than theirs.
Okay, well, we have time maybe for one last question. If there's any final burning question that you've been hoping to ask but haven't found the moment to do so, now's your opportunity. Yes, Sanjoy, please. How fitting.
So this is my sort of very low-level research. Outside WHO offices in Delhi, there's a pan seller. He also sells chewing gum and mouth fresheners. I went for, you'll be happy to hear, chewing gum. Then I said I'll buy my mouth freshener as well. And then he asked me, Mufat mein chahiye, meaning do you want something free? And that was a sachet of tobacco. So the strategy now is not to sell the tobacco at all. What they sell is the mouth freshener. And then they ask you, do you want the free stuff as well? And the free stuff is tobacco. So they're adapting to the laws and selling, not selling, but they're actually selling another product, but then giving you free tobacco with it. So I was wondering that the market is always very clever. How does one then adapt
Yeah.
to their adaptation?
I won't attempt to rephrase what you said, but I guess the basic question is around the way that people find loopholes and adapt to regulations and so forth. So perhaps perhaps the large question around that is the work that you're doing is never over. I guess you're constantly having to adapt your strategies, your health promotion activities, your approaches, and even though the trend is going in the right direction, there's never a moment to stop. Is that right?
Definitely, yeah. Because much effort should be taken to maintain the status once achieved. Achieving is somewhat not so difficult than maintaining the status. So you have to strengthen your efforts to maintain even. Then for sometimes the actual residual effect you can see later. In Sri Lanka, when the act was passed in the parliament, drastical decrease. So we never mentioned that because we know that it's the impact of a sudden change. But after some times, after 6 months, like we measure, it was not so drastical, but considerable. The residual effect you have to take. Otherwise, soon after the effect, so much. That means this is possible. This kind of thing is possible. You have to make, once this becomes a social norm, I think the situation will be much better. So now we have made the norm is not to smoke, because earlier the vigorous campaign. That is why I put that slide, especially the more than our own Sri Lankan, but Indian movies are very popular. And when your, iconic, star is smoking, you tend to follow him. So if these things, this is the stop, I think, because you accept as the particular actor as a hero of your own life. So these things should be, that is why this is cross-border issue. We have to work together, and even when one country implement very good strategies, but still they are influenced by other countries, because this is because of the globalization. People not look at your own national films, but going for other things, and the continuous exposure of these things might alter your, if you have a strong will, it will not happen, but we must continuously put our efforts, and it should be a routine. Once achieved, we have to maintain and improve.
So on that note, I want to draw the seminar to a close. Thank you all very much for coming. For your information, we're going to be running another seminar in 2 weeks' time on the 8th of May, which will be live broadcast. It won't be here at University of York, but it will be live broadcast on the web. And this is going to be about cultural participation in health. How can art potentially save lives? So that's something perhaps to look out for, and the details will be available on the York Global Health Histories seminar website. So it just remains for me to say thank you so much to our speakers, Professor Kamran Siddiqi and of course Dr. Lakshmi Somatunga. It's been a real pleasure listening to you. Thank you for your time and your insight. And to everybody, have a good afternoon. Thank you.